Good morning. Today we will be discussing about a clinical prediction rule. So first, as I mentioned, the clinical prediction rule is a clinical tool that quantifies the individual contributions in, let's say, history, examination or lab tests, and how those individual variables contribute towards the diagnosis, prognosis or the response to treatment in an individual patient. So it's a tool which helps us to predict the future. So in this case scenario, let's look at the 65-year-old gentleman who was recently admitted with a cerebrovascular accident. Discharged 3 months ago, currently is bedbound, has currently now come to the hospital with breathing difficulty. On examination, he was noted to be tachycardic, heart rate of 120 per minute. He was tachypneic with a respiratory rate of 24 per minute, and he was hypoxemic. Saturation was 91%. His chest was clear, and he was hemodynamically stable. Blood pressure was 100/80. Coming to comorbidities, we had comorbidities of COPD and diabetes mellitus. A few investigations, lactates were 3 millimoles per liter, cardiac enzymes were not elevated, and echo showed right ventricular dysfunction. A CT pulmonary angiography confirmed the diagnosis of an acute pulmonary embolism. So this is a patient who presented with an acute pulmonary embolism but is hemodynamically stable at presentation. Now the relatives ask you about the prognosis of the patient. So we will look at this article which we found after literature search and whether the results in this article can be applied to such a patient. So this is the article that we looked at. We looked at hemodynamically stable patients with acute pulmonary embolism and we looked at risk of in-hospital death. In this article they've looked at different models to predict the risk. We will go through each of them. So coming to the boycott statement, the patient population that was looked at were patients aged more than 18 years with symptomatic, objectively confirmed pulmonary embolism. By objectively confirmed, they have done CT pulmonary angiography for around 96% of the patients, and in a few others they've done lung perfusion scans and the others. The exposure we will see in the subsequent slides. There are different scores and we will see what the variables are in each score. The outcome, as I mentioned, was a composite of in-hospital death within 30 days or clinical deterioration. How they define clinical deterioration we will again see in subsequent slides, and the time period was 30 days. So coming to the first question, is the clinical prediction rule clearly defined? So we will look at different aspects. One, the type of patients that they've looked at, which we have seen, more than 18 years of age, with patients with symptomatic, objectively confirmed pulmonary angiography, pulmonary embolism, that is with CT angiography in most of the patients, and patients needed to be hemodynamically stable, that is with a systolic blood pressure more than or equal to 90. So the type of patients for whom the clinical rule can be applied is clearly defined. Now coming to the variables. So these are the different models that we've looked at. The ESC or the European Society of Cardiology 2014 and 2019 models, the PITO model, BOVA scores, and TLOS, FAST and NEWS2. As we can see, each of these scores have different variables like echocardiography and troponin T, and systolic blood pressure cutoffs, respiratory rate cutoffs, heart rate, and they have assigned few categories like the ESC model. They have divided into 3 groups: low risk, intermediate, and intermediate high. Whereas in other categories like the BOVA score, they have assigned scores of 0, 1, and 2, and based on the points, they have divided them into 3 groups in this score. Whether if class 1 if it's 0 to 2 points, class 2 3 to 4 points, class 3 more than 4 points. So like that, each of these scores have risk stratified patients into different groups. We can see the TLOS score as well. Patients are divided into 3 groups based on their points, and FAST score they are divided into 2 groups, and NEWS2 also divides them into 3 groups. So these are the scores that this study has looked at, whether we can risk stratify patients who come with pulmonary embolism who are hemodynamically stable at presentation. Now in ESC model we saw that there was a simplified pulmonary embolism severity index, and the components in that are these: age, history of cancer, history of chronic cardiopulmonary disease, pulse rate, systolic blood pressure, and arterial blood oxygen saturation. Based on these, we can classify them into a low or a high risk group. That is what is used in the ESC. So we can see that almost all the variables are fairly objective. Heart rate cutoffs, saturation, but there could be some subjectivity in terms of the echocardiography based on who has done the echocardiography at different, and the systolic BP cutoffs if they are doing manual systolic BP. And NEWS2 has a variable called supplemental oxygen requirement. So supplemental oxygen is around a score of 2. So different doctors may use different cutoffs to start supplemental oxygen. That is again a bit subjective. But overall, all the other variables are fairly objective. Coming to the outcome, the primary outcome, as we already mentioned, is the composite of in-hospital death within 30 days or clinical deterioration. Clinical deterioration has been defined as at least one of these. One is need for CPR or systolic BP less than 90 for at least 15 minutes, or a drop of systolic BP by 40 millimeters for at least 15 minutes with signs of end-organ hypoperfusion, or need for catecholamine infusion. They have written except for dopamine, which was not very clear.
That is they gave a renal dose. This is an old one. When I was at registrar, if you want to improve renal perfusion, you give 2 mics of dopamine. So it improves renal perfusion in ICU, critical care. It does, but they thought that will improve outcomes or reduce the need of reduce acute kidney injury and reduce need for dialysis in ICU. Nowadays nobody gives renal dose dopamine. That's it. So it's not given for organ dysfunction, which is prevent or renal dose it's called.
So this was the clinical deterioration that they looked at least if the patient fulfilled one of these. The other outcomes that they looked at were in-hospital death, death due to any cause at 30 days, and death due to pulmonary embolism at 30 days. Death due to pulmonary embolism was classified as by ruling out all the other causes. If there was no other cause or post-mortem findings showed cause suggestive to be pulmonary embolism, they would classify it as death due to pulmonary embolism. So coming to the second question, so first question, we've seen that the patient population, the variables have been clearly defined. And coming to the second question, we want to see if the population from which these rules were derived were appropriate. So we've looked at various scores. We'll see whether these scores have been derived in the population that we are going to look at. So coming to the pulmonary embolism severity index, which was used in the ESC scores. That has been derived from patients who are acute symptomatic pulmonary embolism, again confirmed by objective testing, which could be a CT pulmonary angiography or a lung perfusion scan. But they looked at all patients, not just hemodynamically unstable patients, hemodynamically stable patients. They looked at even unstable patients as well. While all the other scores have looked at normotensive adult patients with objectively confirmed pulmonary embolism. Except in PETO, they required lab tests for cardiac enzymes, and they needed dysfunction of the echocardiography. But all the other patient population looked at normotensive patients with a systolic BP cutoff of more than 90 and objectively confirmed pulmonary embolism. So we can see that the population from which these rules were derived is fairly good, and it's a broad population. So these were the studies which I looked at to see whether see what the population was. And we have seen that in the previous slide. From these studies, these are the derivation studies, and we can see that the population is fairly the same as what they are looking at in this study as well. Coming to the next question, was the rule validated in a different group of patients? So we have seen that the rule has been derived from a population which is hemodynamically stable, objectively confirmed pulmonary embolism. Now, has this rule been validated? This is also a validatory study. We are doing external validation. But are there other studies which have validated these scores? So this is a study which looked at patients more than 18 years, again with objectively confirmed pulmonary embolism, and they compared these scores, the ESC 2014 with the BOA and the Cliro score. And we can see that it is externally validated with the positive likelihood and negative likelihood ratios. They have looked at sensitivity and specificity, and these scores have been validated in this study. This looked at 994 patients. And it was a multi-center and 2 monocentric cohorts, which they have validated these scores in. Coming to the BOA model, again, has been validated in 1083 patients who were hemodynamically stable with a cutoff of more than 90, and they reported sensitivity, specificity, and positive and negative likelihood ratios. This is another study which looked at validation of the BOA model. Coming to the news too, this has not been validated in patients with acute pulmonary embolism. The FAST score, this is another study which looked at 868 patients in So coming back to the validatory studies, the FAST score has also been compared. This study looked at the modified FAST, BOBA and the 2019 ESC scores, 868 patients in an Italian pulmonary embolism registry, and they have validated it. They have looked at again sensitivity, specificity and likelihood ratios, and this has also been validated. I have just put the studies which we had looked. These are the validated studies which looked at the results we just looked at. Now is it worth continuing? So we can see that the scores that we are looking at have been derived from a group of patients, and these scores have also been validated in a different group of patients. So it is worth continuing in this clinical prediction rule. We look at what they found out in our study. So coming to whether the predictor variables and the outcomes were evaluated in a blinded fashion. So this is not very clear from this study because they have not said whether the people evaluating the outcome knew the predictor variables or whether the people evaluating the predictor variables knew the outcome. So, but however, they looked at death, which is a hard outcome. So blinding will not have much of an effect on death. But clinical deterioration, however, requires blinding because that has multiple variables in it. So they have just reported that the physicians were advised to treat as per their standard of care. So if the patient was under them, they had the freedom to treat as per their standard of care. There was no guideline on them or pressure on them. So it was not very clear whether it was blinded. Coming to whether the predictor variables and outcome were evaluated in the whole sample that they selected. So if we can look at the scores had different variables, like some required echocardiography to assess right ventricular dysfunction, some required cardiac troponins. So all patients may not have had these values. So they have divided it into a primary study population and a complete case population. The primary study population is the entire group that they looked at, which was around 5,000 patients. And the missing values, like namely the echocardiographic finding, the troponins which were not there for the other patients, they have added it using multiple imputation methodologies. So they have looked at that, which is the primary study population, the entire population, and they have also done the separate analysis for a complete case population, which is only the patients who had all the variables measured. That was around 3,000. So they have done both. And what are the statistical methods used? They have used logistic regression to come to the results. They have used univariate and multivariate analysis, and they have also reported odds ratios. We will also see C statistics, which looks at discrimination and calibration indices and ROC curves, as well as positive and negative predictive values. We will come to these in the results. So the statistical methods were clearly defined and adequately described. Now the tripod statement was used for reporting, which is again a transparent reporting of a multivariable prediction model. And this particular reporting statement has 6 sections and 22 questions. The 6 sections, I just put a picture which looks at each of these. Titles, introduction, methods to do, it looks at the results, the discussion. So this has been reported as per the tripod statement. And they've used SPSS and R project for statistical computing. Coming to the results. So as we already saw, they are divided into a primary study and a complete case population. The primary population, which looked at the entire population, and complete case, which had all the variables. So the primary population was 5,036, while the complete case population was 3,544. Now the primary outcome, which is in-hospital death within 30 days called clinical deterioration, occurred in 4.1% in the primary population and 3.6% in the complete case population. Now, to answer these questions, can the performance of the rule be calculated? For that, we will look at the results in the subsequent slides and how precise was the treatment effect. We will move on to the results. First is the multivariate analysis. So here we have looked at the scores and the odds ratio with the confidence intervals. So the ones that are marked in the red box are the ones that have good odds ratios, and the ones in the blue box are the ones which have not shown a relation. So in the ESC and the PICO models, we can see that all these individual variables by itself had a positive odds ratio. Especially if you look at right ventricular dysfunction and increased troponin, the odds ratio was 4.4. And if you look at death due to pulmonary embolism, and we look at the right ventricular dysfunction and troponin, that is 14.336, varying from 1.89 to 108. So, but if you look at syncope in the fast score, that was to either side. So it was an odds ratio of 0.8. So syncope may not have had an effect on the primary outcome, while all these other variables did have an effect. Now looking at the BOA score as well, the individual variables all had a positive odds ratio, but these marked in blue, namely the heart rate and the oxygen saturation cutoffs, did not have a significant relation with the primary outcome, which was in hospital death or clinical deterioration within 30 days. Now this looked at the rate of the study outcome events. So we've seen that the scores classify patients into different risk categories. So we want to see if the higher risk category had higher rates of the primary outcome, which was the in-hospital death or clinical deterioration. We can see that in the ESC scores, the FAST, BOA, all the other scores except the PICO score, when the risk stratification increased, the percentage of people who developed the primary outcome also increased. So from 1.3 to 8.4, 0.3 to 6.6, and in the other studies as well, except for the PICO study. So all the other scores had a higher population of patients having the primary outcome as their risk stratification went to the higher range. Now this is just a diagram to see what percentage of the primary population they classified into different groups. White being low risk and red being the highest risk. So we can see that in this in the BOA model, they have classified only 16.4% patients as in the high risk category. So again, we do not want a lot of people to be classified as high risk, because that would mean more patients admitted to the hospital and overburden of the hospital facility. So we want the BOA score showed classified these many patients as high risk, that is 16.4%, while the ESC showed 21.7 as low risk. That means they could be managed as outpatient. So this was the risk stratification among different scores. We look at the predictive values subsequently. So now looking at the negative and the positive predictive values. So the negative predictive value has been done in each score in the low risk category, and the positive predictive value has been done in each score in the high risk category. So when we look at the negative predictive score, ESC 2019 had a high negative predictive score. So if you can see that ESC score also had the lowest number of people in the low risk. So they had the lowest number of people in the lower risk category with the highest negative predictive value. So that is a good score to categorize patients who can be managed as outpatient. While we look at the positive predictive values, none of the scores had great positive predictive values. The maximum was only 13.8 in the new score, and 10.4, 9.3, 8.5. So the scores did not have a good positive predictive value. But if you look at the negative predictive value for the secondary outcome, which is death due to pulmonary embolism, it was above 99 in almost all the scores. So the scores could predict, had a good negative predictive value for death due to pulmonary embolism. This is the primary analysis population, which is the 5,000, and the other population, which is the complete case population, also showed similar positive and negative predictive values. Coming to the C statistic. So C statistic is a goodness of it to see if we select any person at random and they have the outcome, whether they have a higher risk score. So that it's a statistic to look at how those two are related. So if the C statistic is more than 0.7, it means that it is a good relation. So we can see that in the TLOS and the ESC scores, C statistics have been more than 0.7 for the primary outcome for in-hospital death and clinical deterioration. But the 30-day death due to any cause had quite poor relation because it was all less than 0.7. So the ESC and TLOS had good C statistics. Now that is again reflected in the ROC curves. So as the ROC curve moves closer to the y-axis, which is the sensitivity, it is a better predictor. So we can see that the TLOS, which is the black line, and the ESC, which is the dotted red line, or the straight red line, were more towards the y-axis. Means that these scores, ESC and the TLOS, had good predictive value, as we saw in our C statistic as well. Now these are calibration models. Now this is looking at if the scores are well calibrated. Now if it is well calibrated, it means that they should fall along the diagonal line. If it is less or below the diagonal line, it's an overestimation, but if it's above, it's an underestimation. So we can see that these scores for the ESC and ESC scores have been well calibrated, but the TLOS and the BOBA are slightly overestimation. That is, they are below the diagonal line. Now, when we look at these, they have mentioned ROC curves, but they have not given individual sensitivity, specificity, and likelihood ratios, which we would have liked to see. They have explained it by saying that, as we've already seen, the ESC model had the lowest rate of in-hospital death with the highest negative predictive value. So, it could be used to identify patients suitable for outpatient management. They have also written that the other scores had the lowest prevalence of high-risk patients with the highest event rate. But again, we saw that the positive predictive values were not too high. It was only around 10%. So the ESC model could be used for outpatient management, but the others may not be good to predict the primary outcome. Now, will the results set locally? The study had no Indian population first. But when we look at the basic characteristics, if we remember the case we had discussed in the beginning, our patient was less than 80 years old, which is around 70% of this population, and he had a systolic BP of 100 by 80, along with a heart rate of 120. So we can see that if we can fit our patient into the patient population that they have looked at. So it can be applied locally to our scenario as well. And our patient had comorbidities of COPD and had right ventricular dysfunction, which was there in around 16 and 48% of these patients. So I would say we can apply this clinical prediction rule to our setting, and the variables that they have used, is the rule acceptable in our case? They have used fairly simple variables, the systolic BP, saturation cutoffs, echocardiography, not too expensive and can be easily done for our patients as well. So the variables are all readily available in our hospital and are inexpensive. Now, will it change or modify the decision about management of the patient? First of all the scores had poor positive predictive values. The negative predictive values were good for a lot of the scores. But I would use the individual variables, like we saw that right ventricular dysfunction and troponin together had a good odds ratio. So it would be better to use individual variables rather than a complete score for our clinical decision making based on this. So coming to our case scenario, again we saw a 65-year-old gentleman who presented with objectively diagnosed pulmonary embolism and was hemodynamically stable. So how would we proceed? Will we use any of these prediction models, or would we use the different variables? So we can use the ESC score to predict outpatient management, but to predict our primary outcome, which was in hospital death or clinical deterioration, I would rather look at the individual variables like a right ventricular dysfunction or elevated cardiac troponins rather than take any of these scores, as they had poor positive predictive values.